Recording in progress.
Good evening, distinguished guests. On behalf of Sun Pharma Grassland Life Division, we extend a very warm, hearty welcome to you all for this very interesting webinar titled Pearls in the Management of Rheumatoid Arthritis, a clinical practice-oriented lecture. Warm welcome, respected doctors, once again. With immense pleasure, we also take this occasion to welcome the speaker of this evening, Dr. S. Ramakrishnan, eminent senior consultant rheumatologist of Chennai with 33 years of experience in rheumatology. Sir, a very, very warm welcome to you, sir.
Thank you. Thank you very much.
And it is a great pleasure to have you today in this program, sir. Respected doctors, I take this occasion to share a few of the doctor's credentials, that is professional, academic and professional achievements of Dr. Ramakrishnan before we hand over the session to him. Doctor is one of the first qualified senior rheumatologist of India. While sharing his academic achievements, while in MBBS, Sir has won lots of gold medals. In fact, in first year, he won the gold medal for physics. In second year, he has won the gold medal for biochemistry. Third year, he has won the gold medal for pharmacology. And fourth year, gold medal for pathology. He also won Dr. K.P. Sarathi medal in the highest marks in final MBBS. And Doctor has won K.M. Jagadish Ramachandran Memorial Medal for obstetrics and gynecology. Sir has also won Dr. Ratnavel Subramanian's gold medal for the best outstanding students of the batch. He also won the Shering A.G. gold medal in obstetrics and gynecology. Sir has also won Dr. A. Srinivasan medal in 1978 for securing the highest number of marks in theory and clinical examination at the part 2 of final MBBS in Madras University. Sir has also won the A.C. Asirvada Nadar Memorial Prize in 1978 for securing the highest number of marks in clinical examination and clinical obstetrics in final MBBS in Madras University. He also won the A. Guruswami Mudaliar Prize for passing several examinations in MBBS in first appearance and securing the highest number of marks in pharmacology, pathology, and in medicine. Sir has also won the IRA Boots Best Paper Award for the paper entitled Our Experience in Psoriatic Arthropathy in the International Conference of Rheumatology held at Goa in November 1987. Ramakrishnan sir has been a member of several prestigious associations, and he is a life member of Association of Physicians of India, Indian Rheumatology Association, Asia Pacific League Against Rheumatism, Indian Medical Association, and he is also a life member in the Indian Menopausal Society. Doctor has also functioned as an associate editor in Indian Journal of Indian Rheumatism Association presently. Now it is called as Indian Journal of Rheumatology. Sir has published over 38 articles in various national and international journals, and he also presented 40 papers in various national and international journals. And he had been honored and conferred with Professor Emeritus by Tamil Nadu MGR Medical University. Sir has delivered orations in various societies, academic forums like Indian Academy of Pediatrics, Indian Orthopedic Association, Indian Medical Association, Association of Physicians of India, Associations of Occupational Health. Sir has been regularly teaching rheumatology to the students of various disciplines of medicine, including MBBS students, DNB General Medicine students, MD General Medicine students, Diploma in Orthopedics, MS Orthopedics, Diploma in Dermatology, MD Dermatology, DNB Pediatrics, DNB Respiratory Medicine, DNB Gastroenterology, DNB Obstetrics and Gynecology, Diploma in Physiotherapy, and Bachelor in Physiotherapy. Sir has also worked as an assistant professor of rheumatology in Madras Medical College and Government Hospital, Chennai from 1983 to 1994. His areas of interest are diagnosis and management of various rheumatic diseases, antiphospholipid antibody syndrome and recurrent pregnancy loss, experience in the management of nearly 4,000 patients with obstetrics, antiphospholipid antibody syndrome and recurrent pregnancy loss, management of neonatal lupus with complete heart block, IgG4 disease diagnosis and management, biologics use in various rheumatic diseases, high involvement in rheumatic diseases, management of connective tissue diseases related to lung disease, and also vasculitis diagnosis and management. Currently, Ramakrishnan sir is working as a senior consultant rheumatologist in Apollo Greaves Road Hospital, Chennai for the past 25 years. He is also a visiting consultant in Apollo Medical Center, Anna Nagar, Chennai for the last 15 years. Sir's other areas of interest are spiritual. He has got a special interest in spirituality, and he is an author of the blog called wisdomramki.com. He's also a humorist, and Sir regularly participates in the patient education program on rheumatology in televisions, All India Radio, and also various newspapers in English and Tamil. Thank you, sir. Thank you very much for this opportunity to share few of your credential, professional, academic achievements with the audience, with our audience today. Once again, a very warm welcome to you. And I hand over the session to you, sir, for further proceedings. Thank you very much.
Thank you very much. I should really thank Sun Pharma for giving me an opportunity to be speaking to all of you this evening. I shall tell you one thing. It's going to be a talk with absolute clarity. And anybody who listens to that lecture can go tomorrow morning and start practicing the management of rheumatoid arthritis. It will not be high-flown immunology, and I intend to make the lecture as simple as possible. Now, all of us in life who have a dilemma whom to choose before marriage, and some of us may have a dilemma even after marriage. I'm not speaking with respect to the statement made above, but what options do you have to choose in the management of rheumatoid arthritis? Now, rheumatoid arthritis is a symmetrical polyarthritis which affects the smaller joints of the hands and the feet, associated with significant morning stiffness. Left untreated, patients can land up with these deformities like you see here, swan neck deformities and deformities of the toes, the feet, etc. It ultimately interferes with the activities of daily living and makes the patient being totally dependent on others. I, as a rheumatologist, will never like and love to see patients at this stage of the disease. In fact, it will upset me very badly. So we have to treat rheumatoid arthritis as early as possible. You can ask me a question, what are the treatment goals? Basically, rheumatoid arthritis is an auto-inflammatory disease. It's an autoimmune disease. So you have to induce remission, inducing remission like in malignancy. If you do not induce remission, then you have to achieve a low disease activity. After achieving a remission or achieving a low disease activity, then you have to maintain remission. Now, this disease is known for its relapse and its remissions. So you should also be able to tackle flares in rheumatoid arthritis. And rheumatoid arthritis is not purely an arthritic disease. It can affect the eye, it can affect the lungs, it can affect the kidney. So many organs can get affected, especially the eye and lung, especially interstitial lung disease. So the treatment goals is going to be very holistic, but most important factors, you have to treat rheumatoid arthritis aggressively to induce remission and maintain remission. That's very, very important. Now, how do you make a diagnosis of rheumatoid arthritis? Now, it is a clinical diagnosis as far as the rheumatoid is concerned, that it is a symmetrical inflammatory polyarthritis. Occasionally, it can also be asymmetrical. But the most important point, it's very, very associated with early morning stiffness, significantly even going for 30 minutes to an hour. That's important. And the other important point, it affects women more than men. It can occur in the adolescent group, in the middle age group, and you have rheumatoid arthritis affecting even the elderly. But important truth is, all patients who are rheumatoid factor positive do not have rheumatoid arthritis. Rheumatoid factor can be positive in about 5 to 10% of the normal population. It can be positive in tuberculosis. It can be positive in Hansen, lymphomas, other malignancies. It can be positive also in connective tissue diseases like systemic lupus, positive in hepatitis B. And so what I mean to say is that every patient who's got every subject who has got a rheumatoid factor positive, it does not mean he has rheumatoid arthritis. The second point is all patients with rheumatoid need not be rheumatoid factor positive. Only about 70 to 80% of them are rheumatoid factor positive. So we have a group of people who have a diagnosis of rheumatoid arthritis based on clinical grounds, but the rheumatoid factor can be negative. The third important investigation which you do in rheumatoid arthritis, you have to estimate the C-reactive protein serially once in 3 months or once in 6 months to monitor the disease and also assess the response to treatment. So rheumatoid factor present does not mean it is rheumatoid, and rheumatoid factor absent, it does not mean it's not rheumatoid. That's the most important truth. Now, what is the treatment of rheumatoid arthritis? The mantra. The mantra will be early diagnosis is very important. Early treatment is absolutely very, very important. And this is a question which I have answered, and I'll tell you to all my colleagues, every rheumatoid arthritis patient should be treated with disease-modifying anti-rheumatic drugs. 35 years ago, when I started my career as a rheumatologist, we used to wait to start disease-modifying anti-rheumatic drugs. We'll give them NSAIDs, and we'll give steroids. We'll wait for 6 months to 1 year, and by the time the whole damage is done. So nowadays, the important truth is early diagnosis, early treatment, treat all rheumatoid arthritis patients with disease-modifying anti-rheumatic drugs. Now, why should I treat rheumatoid arthritis early? Rheumatoid arthritis is associated with significant morbidity, that is destruction of the joint, resulting in deformity, disability, and it affects the activities of daily living. The second important fact is, don't think that rheumatoid arthritis patients will have normal longevity of life as a normal population. It can be associated with significant mortality because there's a great incidence of premature ischemic heart disease in patients with rheumatoid. And the third point is very, very important. Maximal damage to the joint occurs within 2 years of onset of the disease. That's very, very important. This 2 years rheumatoid arthritis onset, this is give you a window of opportunity to treat the patient. Number one, before we used to have a pyramidal approach in the treatment of rheumatoid arthritis. First NSAIDs, then steroids, then disease-modifying drugs, then we have immunosuppressive drugs. Now, what we rheumatologists tell everybody is start treating rheumatoid arthritis early, leave the pyramid to the Egyptians or the Talibans. So the important point is treat RA very early. Early diagnosis, early treatment, early initiation of treatment is an absolute important principle in the management of rheumatoid arthritis. So what did I say? You have to achieve disease control as early as possible, even as early as 6 months as possible. This is very, very important. Achieve remission or low disease activity within 6 months of treatment. This will be ideal and an ideal situation in an utopian situation as such. We may not be able to do it in all, at least in 50 to 60% of patients with aggressive early treatment, you can do that. Now we have a criteria. You can ask me, Dr. Ramakrishnan, here is a patient with rheumatoid arthritis. You have started treatment and you say that in 6 months he should go into remission. What do you mean by remission? Remission means patient does not have joint pain. The tender joint count is less than 1. Swollen joint count is less than 1. Excuse me, can you mute people who are talking in between, please? C-reactive protein is less than 1 milligrams. I think you got to meet people. Yeah, very important. So I just go down history. I joined the rheumatology department, say about 1990. Prior to that, it was just symptom relief. Just give non-steroidal anti-inflammatory drugs. You have the ego that you made a diagnosis of rheumatoid, you lift your collar up, and then you give your heartfelt condolences saying, I cannot do anything for you. It's a shame. Then 1990 to 2010, disease modification. We had disease-modifying anti-rheumatic drugs like methotrexate, sulfasalazine, hydroxychloroquine. Then biologics. Now you know what is the objective of management? Induce remission. So the slogan for the treatment of rheumatoid arthritis, the mantra today will be treat rheumatoid arthritis aggressively to see to it that they get into remission. That's a very, very important point, like how people treat malignancy. When you get into malignancy, people do not give symptomatic treatment with steroids or something like that. Nowadays, you have wonderful agents for chemotherapeutic agents and immunotherapy in malignancy. We are capable of inducing remission. Gone are the days when lymphoma people will die like flies. Gone are the days when people with leukemias will die. Gone are the days when patients with rheumatoid arthritis will have a crippling deformity because you have wonderful drugs now available to induce a remission. Let us come to the treatment overview. The treatment overview, one side you have pharmacological therapy with medications. The other side you have non-pharmacological therapy. What do you mean by non-pharmacological therapy? Important, educate the patient. Don't treat the disease, but treat the patient. That's very, very important. It is the patient who has the disease. So you have to educate him about the chronic nature of the disease. In fact, I put it in a rubber stamp in my prescription. Disease not curable, only controllable. With that, the patient comes to me, it's all right. If he doesn't come, I cannot help it. It is karma. That's all. So tell them it's not curable. It is controllable. Aggressive treatment can be given. Medications can be associated with side effects. Get them to a physiotherapy program. Get them into yoga, meditation, relaxation exercises. There is no specific diet for rheumatoid arthritis at all. People will come and say whether I can take tubers, whether I can take this. You can eat anything you want under the sun. But fish oils, in fact, eating fish with people with rheumatoid eating fish, it contains a lot of substances which prevents the formation of inflammatory prostaglandins. So fish is well advocated in this. Most important is a well-balanced, nutritious diet. So physiotherapy is absolutely must. And last but not the least, the family should give psychosocial support to a patient with rheumatoid. Just imagine if one of us have rheumatoid arthritis and we cannot do our activities of daily living and we have to depend on people, it's very depressing. So very important, you have to look holistically at a patient with rheumatoid arthritis. So coming down to the pharmacological therapy, these are all the important drugs we have. We have non-disease modifying medications like non-steroidal anti-inflammatory agents and steroids. You have disease modifying anti-rheumatic drugs, which we call non-biologic and biologics. Last is surgery, where joint replacement will be done. We have wonderful surgeons in this country replacing so many joints. So the most important point is the physician and the orthopedic surgeon are there. And very important, we have wonderful orthopedic surgeons available. I have had patients, one patient, I've had 3-4 patients, I've had a shoulder replacement, an elbow replacement, a knee replacement, and a hip replacement. So we cannot forget the species of orthopedic surgeons who will be able to see to it that these patients are mobile and they get back their activities of daily living. Coming down to non-steroidal anti-inflammatory drugs, they are anti-inflammatory. They extinguish the fire of inflammation. Now, one important point, there is an individual variability in response to various NSAIDs. If 10 of us develop rheumatoid arthritis, unfortunately, including me also, I may respond to indomethacin, he may respond to diclofenac sodium, he may respond to naproxen, he may respond to piroxicam. So we do not know who will respond to what. So what is the most important principle? You have to wait for at least 2 weeks before changing the NSAID. What people do is indomethacin for 2 days, ibuprofen for 3 days, diclofenac sodium for 3 days. It improves the share value of 3 pharmaceutical companies, but it also makes the patient poor. You have to wait for 2 weeks at least before changing the NSAID. The other group of mistake which all of us do is ibuprofen in the morning, diclofenac sodium in the afternoon, piroxicam in the evening, celecoxib in the night. What a cocktail of non-steroidal anti-inflammatory drugs for the weekend. Do not combine NSAIDs. Important principle, wait for a couple of weeks before you're changing and do not combine non-steroidal anti-inflammatory agents. That's very important. And why do you use non-steroidal anti-inflammatory drugs in the treatment of rheumatoid? It's mainly used for symptom relief. And you take disease-modifying anti-rheumatic drugs, they take nearly 8 weeks to 3 months to start acting. So to bridge that gap, you can give non-steroidal anti-inflammatory drugs. You can use it when there's a disease flare. My principle is very simple. that we do not give non-steroidal anti-inflammatory drugs for a prolonged period of time, because once the rheumatoid becomes very quiescent, you can be used as and needed. That's very important. So suppose rheumatoid arthritis is there in a patient, it doesn't mean lifelong non-steroidal anti-inflammatory drugs. Why not lifelong? They have side effects. They can cause stomach ulcers, NSAID-induced gastropathy. They can knock out the kidney, interstitial nephritis, so they can cause nephropathy. Be very, very careful. In fact, avoid non-steroidals in patients with bronchial asthma because it can precipitate bronchial asthma. And some non-steroidal anti-inflammatory drugs can even precipitate ischemic heart disease. So one important fact is no indiscriminate usage of non-steroidal anti-inflammatory drugs, and do not sentence rheumatoid arthritis patients to lifelong imprisonment with NSAIDs. That's important. Now, what about steroids? Now, steroids were discovered by Professor Robert Hench 100 years ago. But he sent an email to me from heaven. Definitely he's in heaven only, he's not in hell. He cried in the email and told me, Ramki, I'm extremely upset. Steroids are highly misused in this world. Bronchial asthma gives a lot of steroids. Rheumatoid arthritis, okay, fine. Patient wants to leave, take steroids for a long period of time. And our patients are extremely shrewd. And pharmacies can also give it just drug across the counter. They don't even need a prescription. Not only things are becoming better. When we give steroids to a patient, the patient becomes much better and he does not come. He becomes a doctor and he continues steroids for about 10 years, comes back with a Cushing-Art fissures, with a cataract, with a glaucoma, with osteoporosis, with diabetes, with hypertension. So steroids are highly misused in the treatment of rheumatoid arthritis, and we should be very, very careful. When do we give steroids? I told you it takes 3 months for the disease-modifying drugs to start kicking in their action. So you can give it low-dose steroids, prednisolone, 5 to 7 milligrams per day for about 3 months. Number 2, steroids do not have any disease-modifying potential. No use. They do not alter the disease process at all. Please be aware of the long-term side effects. Risk of self-medication is very high in India. And intra-articular steroids, you should be careful of introducing intra-articular sepsis. That's important. So what is the main objective? Try to discontinue steroids as early as possible. And some people become steroid dependent. That's important. Now, the most important drug in the treatment of rheumatoid arthritis, we controlled inflammation with non-steroidal anti-inflammatory drugs, but we control also rheumatoid arthritis inflammation with steroids, but none of these drugs have a disease-modifying effect at all. So the only drug which has got a disease-modifying effect is disease-modifying anti-rheumatic drugs, which are the cornerstone of the treatment of rheumatoid arthritis. Diagnose rheumatoid arthritis early, start treating them with disease-modifying anti-rheumatic drugs, and utilize this window of opportunity to control the disease. That's very, very important. All rheumatoids, start them on disease-modifying anti-rheumatic drugs. Now, which are the common disease-modifying anti-rheumatic drugs, which are called synthetic disease-modifying drugs? One is hydroxychloroquine, which made a big name in the world with COVID. Then you have sulfasalazine, which is more used in Britain than US. You have methotrexate, which is a darling drug for the rheumatologist. In fact, rheumatoid arthritis is something like a methotrexate deficiency disease. The moment it is rheumatoid arthritis, we start them on methotrexate. Leflunomide is another molecule which we use in patients who are resistant to methotrexate therapy. I shall discuss only 2 important drugs. Rheumatoid arthritis, methotrexate, rheumatoid arthritis, methotrexate. That is the slogan which I will definitely keep telling this weekend. Methotrexate, it forms the sheet anchor. It is very effective in controlling the disease process. Easily available. It's available in villages also. It's very economical. And we have fortunately both oral and parenteral preparations. All rheumatologists invariably start only with oral preparations. Very rarely they go into parenteral preparations. Now, what is the other advantage of methotrexate? It's a very good combination drug. If you use it with biologics, the efficacy of the biologics improves. Decades of rewarding experience, 30 to 40 years of experience with methotrexate is something which has withstood the test of time, and it's a wonderful drug. If they have nausea, it's a little common in them. What I try to do is to give them immediately after breakfast, and suppose if still the nausea is persisting, I give them ondansetron. Now, what's the normal dosage of methotrexate? Please remember this is one point. Methotrexate is the medicine in rheumatoid which is not given daily. That's very, very important. You have to be very careful when you write a prescription. It is given only once a week. And I prefer to give it on a Sunday so that at least they will remember. See, people that get drunk on Saturday, they may forget to take it on Sunday. That I can't help it. But but anybody takes alcohol, you should not take methotrexate. It's not a good medicine at all. So you should give them orally 15 to 25 milligrams of methotrexate only once a week. What I do in my prescription, I actually, after writing it, I put a box around it to say that you have to take it once a week. I have had patients who have taken it daily, landed up with the ICU with pancytopenia, abnormal liver enzymes, and mucositis. So please tell the patient you have to take it only once a week. If suppose the dose is more than 15 milligrams per week, you can change to the subcutaneous route of administration for better bioavailability. So the most important point I will tell you here again is methotrexate is given only once a week orally, or it is given subcutaneously. Never, 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 never daily. That's important. Now, where are the conditions in which methotrexate is contraindicated? You should never give it to women who are breastfeeding the child. Methotrexate does not compromise fertility. If a male wishes to father a child, he can still take methotrexate. It's not a problem at all. But if a woman wants to conceive, then you should stop methotrexate at least three months prior to attempting conception. 3 months prior to attempting conception, you have to stop the methotrexate. What are the commonest side effects with methotrexate? One is nausea. The second one is stomatitis with oral ulcers. Occasionally, it can cause elevation of liver enzymes. Very rarely, it can cause a fall in the blood count. So for all these precautions, what you have to adopt is you have to monitor the complete blood count, the liver function, serum creatinine, and urine routine once in 4 weeks. That's very, very essential. Every person with methotrexate should be given folic acid. Avoid prescription errors, avoid daily intake of methotrexate, and there's no need for liver biopsy. The second drug which is used by all of us, very mild rheumatoid, is this drug hydroxychloroquine. Good safety profile, economical, easily available. You can give it in a dosage of 200 milligram per day or 300 milligram per day or 400 milligram per day. Hydroxychloroquine is a very safe drug, but the important point is it is only effective in mild rheumatoid arthritis. What are the commonest side effects? Skin hyperpigmentation. They become dark. It can cause a dermatitis, a rash, retinopathy. If anybody takes hydroxychloroquine for a prolonged period of time, hydroxychloroquine has got a great affinity for melanin in the retina, and so these people can land up with chloroquine retinopathy and become blind. Every 6 months, they should undergo a complete eye check, including visual fields. That's important with hydroxychloroquine. Coming down to sulfasalazine, which is not, in fact, a very popular drug because methotrexate has become exceedingly popular. It is effective, good safety profile. The dosage is 1 gram to 2 grams per day. In fact, many of us are not using sulfasalazine in the treatment of rheumatoid arthritis at present. The second important message with respect to the synthetic DMARDs, you can just give methotrexate alone as a monotherapy, or you can combine methotrexate with hydroxychloroquine or methotrexate with sulfasalazine. I think this combination is better to be taken by the rheumatologist. In such situations, if you think the patient needs, it is better to get a rheumatology referral. That's very important. Another important drug which is now being used in the treatment of rheumatoid is a drug called Biologics, which were born as early as about 2000 and 2001. Now, the basic pathophysiology or the pathogenesis of rheumatoid, we have a lot of molecules called cytokines, and these pro-inflammatory cytokines are responsible for the joint destruction and permanent joint destruction and inflammation in rheumatoid arthritis. So what do we do? Biologics are the drugs of choice, are the missiles which target specific pro-inflammatory cytokines like tumor necrosis factor alpha and other pro-inflammatory cytokines. These cytokines are actually responsible for the destruction of the joint, and this is a missile. It is a biologic which will go inside the joint and it will completely hit all the inflammatory cytokines, extinguish the fire of inflammation, and prevent joint destruction. That's very, very important. Just one small word about these drugs. Biological therapies are capable of changing the pathology, or they are inflammatory. In India, we have the original molecule and the biosimilar also. And these biologic medications have been found to even inhibit radiographic progression of the disease. So biologics are wonderful drugs. And I think, in fact, the creator is an extremely kind that he made scientists burn the midnight oil and discover biologics, which are actually the best, one of the best drugs useful in rheumatology management. So the ideal drug is methotrexate, hydroxychloroquine for mild, sulfasalazine, okay, if they're allergic to methotrexate, they don't tolerate methotrexate, milder disease, you can give sulfasalazine. Now, when will you give a biologic? Very simple. When a rheumatoid arthritis patient does not respond to synthetic DMARDs like methotrexate, you'll have to give it. Patients with very aggressive disease with very poor prognostic factors. People who are intolerant to conventional synthetic DMARDs like methotrexate. And when patients have extra-articular manifestations like vasculitis and necrotizing scleritis, in these situations, now we rheumatologists have started becoming very aggressive, and we have started using biologics a little earlier than what it did. Initially, when the biologics came into the market, they were exceedingly costly. So if I tell the patient about the cost of the biologic, he will die of ischemic heart disease due to the shock he gets to the cost. Now we have wonderful biologics made by Indian pharmaceutical companies at a very economical rate when compared even to the original innovator molecule. So they are wonderful drugs which rheumatologists definitely use. I don't want to get into it. Now biologics are like the Indian test team. We have etanercept, infliximab, adalimumab, golimumab, and rituximab. I'm not going to get into all this, which you can always read. But biologics are effective medications to arrest the disease process in rheumatoid. So to sum it up, it will be conventional synthetic DMARDs like methotrexate, sulfasalazine, and hydroxychloroquine. And then you come down to biologics. Biologics, you have various types of molecules. Not only they extinguish the fire of inflammation, but they are capable of even inhibiting radiological damage to the joint. And what are the adverse effects? This is very important. See, as a rheumatologist, I may prescribe a biologic, but he comes to the physician. Now, what happens is there is a sort of a wrong opinion among everybody that biologics are very dangerous medications. They are not very dangerous medications at all. Very rarely they can cause infections like tuberculosis. Otherwise, they are very, very safe drugs. So don't get worried about the side effect. Every drug has got a side effect. Without us, even marriage has got side effects. One marriage, one side effect means many marriages, many side effects. So what I'm just trying to tell you is no medication. If a medication has got an effect, it will definitely have a side effect. So let us not get totally paranoid and frightened about biologics. They are wonderful drugs to treat rheumatoid arthritis. Tuberculosis can be a side effect occurring in about, say, 0.2% or 2% of the population we are put on. We have to watch them for tuberculosis. That's all. Don't get worried about it. But the important point is, anybody before starting a biologic, you will have to do a complete health checkup. It's very important. Pre-biological screening. You will have to screen for HIV, hepatitis B, hepatitis C, and tuberculosis. That's very, very important. This is very, very important. You should have to ask for HBsAg, then you'll have to ask for anti-HCV and HBC core antibody, retroviral 1 and 2. Then you'll have to do a MAN2 test, a TB quantiferon, an X-ray chest. If there are any suspicious changes in the X-ray, you'll have to get a CT of the chest done. Very important, biologics are safe. Occasionally, they can run into tuberculosis. Please do a pre-biological screening. Now, what happened was scientists have burnt the midnight oil and they discovered a very wonderful drug called JAK inhibitors. Now, these JAK inhibitors are actually, they prevent the formation of inflammatory cytokines. They're called small molecules because they act in the intracellular compartment of these inflammatory cells. And you have a wonderful drug which is available in the Indian market today, which is called as tofacitinib. The advantage of tofacitinib when compared to a biologic, biologics are given parenteral, either subcutaneous or intravenous. Tofacitinib is just given orally, and they inhibit the formation of pro-inflammatory cytokines. Now, this drug, tofacitinib, which is a JAK inhibitor, JAK1 inhibitor, it has got comparable therapeutic efficacy with biological DMARDs like etanercept or adalimumab. So trials have clearly established the therapeutic efficacy of this JAK inhibitors in rheumatoid arthritis, that their therapeutic efficacy is equal to that of biologics. So we call them as a poor man's biologic. And the dosage of tofacitinib is to give 5 milligram twice a day orally. Now, when you give tofacitinib, you gave biologic when a patient did not respond to conventional DMARDs like methotrexate, rheumatoid arthritis, aggressive disease with bad prognostic factors, when a patient was intolerant to methotrexate. Now, when do you give this tofacitinib? When people have had inadequate response to conventional synthetic DMARDs like methotrexate, inadequate response to combination of conventional synthetic DMARDs like methotrexate and hydroxychloroquine, methotrexate or sulfasalazine, and they have inadequate response even to biologics. See, biologics had the last say and say that, hey, I am the drug of choice for rheumatoid arthritis, but not all patients with rheumatoid will respond to biologics. About 40% of them may not respond at all. In such situations, you have this wonderful drug tofacitinib available to help to arrest rheumatoid arthritis. And now in the Indian market, see, tofacitinib was originally an innovator molecule. It costed a fortune, but now Indian pharmaceutical companies have come forward with tofacitinib, which actually suits the person of the common man in India. I would rather say it's like the Maruti car. So definitely we patronize tofacitinib in the management of rheumatoid. So what are the unique advantages of tofacitinib? Therapeutic efficacy comparable with biologics. Early onset of action within 2 weeks. This is a very important point. Biologics will take about 4 to 8 weeks for onset of action. Tofacitinib starts its action in 2 weeks. Convenience of oral therapy. I call it a poor man's DMARD. And tofacitinib can be used either as a monotherapy or a combination therapy with methotrexate. The Indian molecule is more economical than the original molecule. Indian molecule has got comparable efficacy and safety profile compared to the original molecule. So in India, the basic advantage, it is cheaper and it's only given orally. So tofacitinib is now picking up its position. Adverse effects, some people can develop herpes zoster. Very rarely it can cause deep vein thrombosis, but the commonest infection, commonest adverse effect, it's very well tolerated. Safety comparable to other biologics. Commonest adverse effect will be an upper respiratory infection or nasopharyngitis. That's all. Very rarely lymphopenia and abnormal lipid profile. So tofacitinib otherwise is seems to be quite a very safe drug. So now I'm coming to the end of my lecture. Here is a patient with rheumatoid arthritis. What will you do? You first make a diagnosis. Diagnosis is clinical plus rheumatoid factor and anti-CCP and CRP. Start the treatment. Ideal drug of choice is methotrexate 15 milligram per week with a small dose of steroids along with NSAIDs. At the end of 3 months, you find out whether the patient has achieved low disease activity. If he has achieved low disease activity, you continue the drug and slowly you can reduce the drug. Suppose this patient at the end of 3 to 6 months has not responded to methotrexate or he's got adverse effect, you'll have to change over to another disease modifying drug like leflunomide. Now, one last important point is, here I have rheumatoid arthritis. I go to the rheumatologist. I will ask the rheumatologist, you please tell me what are the bad prognostic factors. How will you say that my disease is going to behave very badly in compared to another person? If one is a female, the prognosis is bad. Multiple joints affected, prognosis is bad. Early neck and wrist involvement, prognosis is bad. If they are manual laborers, because of excessive mechanical work, they can destroy their joints, prognosis is bad. Positive rheumatoid factor, prognosis is bad. Anti-CCP, definitely it actually forecasts the progressive articular disease. And if they have erosions in the X-ray and MRI, it means the bad prognostic factor. So any rheumatoid arthritis comes, we should write all these things and take it. Females plus bad prognosis. Polyarticular, bad prognosis. Wrist and neck node, bad prognosis. Manual labor, bad prognosis. RA factor positive, anti-CCP, bad prognosis. Erosions, bad prognosis. If they do not have any of them, you can say very good. Your future is absolutely fine. You can be a very good astrologer to predict when you take all these factors into consideration. So the important of this slide, don't get confused about this algorithm. Patient with rheumatoid has not responded to methotrexate. If he has got no prognostic factors, then you can combine with synthetic DMARDs like methotrexate, leflunomide, etc. On the other hand, if he has got poor prognostic factors like being a female or a polyarticular disease or neck involvement, you will have to give either biologics or JAK1 inhibitors. JAK1 inhibitors, advantage, oral, cheaper, onset of action is early as 2 weeks. Biologics, onset of action takes about 4 to 8 weeks, but they're also very wonderful drugs. So what happens is either you choose a JAK inhibitor or a biologics when it comes to the last scope of treatment. How to treat lifelong? One person came and told me, how long to treat rheumatoid arthritis? I said, your lifelong. He said, why are you telling my lifelong? I said, you have the disease. So then I told him, it goes like this. Now we have 3 options available. I'm definitely elder to you. I will kick the bucket. So you have to see another rheumatologist. Very rarely, occasion, you may kick the bucket earlier than me, then there's no problem. When both of us kick the bucket together early, there's no problem at all. Rheumatoid arthritis is a lifelong disease which requires lifelong treatment like diabetes and hypertension. The moment you tell lifelong treatment, you say, oh, lifelong. Why? You take anti-hypertensive lifelong, you take diabetes lifelong, anti-diabetic medications lifelong. Why poor rheumatoid arthritis? Why should you give it stepmotherly treatment? It is a treatment which is given lifelong. But the important point is we monitor the patient and slowly we reduce the drug also. The carry home message. If somebody has slept during the whole structure about 35 minutes, you just wake up now and listen. Carry home message for rheumatoid, symmetrical polyarthritis, early morning stiffness. Rheumatoid factor anti-CC will be positive. Rheumatoid factor positive means that's not its rheumatoid. And in a patient with polyarthritis, the RA factor is negative, it doesn't mean it's not rheumatoid. Very important, early diagnosis, early treatment with disease-modifying anti-rheumatic drugs. Never forget non-pharmacological treatment like patient education and physiotherapy. Pharmacological treatment is very essential. For that, you have non-steroidals, symptomatically, no disease-modifying effect. Think of adverse effects like the kidney and the stomach. Steroids, no disease-modifying effect. Use it only for as much a short period as possible, say for 3 to 6 months. Prednisolone 5 to 7 milligrams per week to bridge the gap. Disease-modifying drugs, wonderful drugs to modify the disease process, retard radiological progression of the disease. The only drug which is a great choice, the rheumatologist's darling choice is methotrexate, wonderful drug, never to be given daily, always once a week it has to be given. It is the sheet anchor of the treatment of rheumatoid arthritis. Then you have biological DMARDs called Biologics, also the darling drug of the rheumatologist, because not only they control inflammation, but also they control the disease process. And India, biosimilars are available at a lower price. One important caution, kindly think of tuberculosis. Fastatinib, the drug which recently has come into the Indian market, the great advantages are early onset of action, easy of administration because it's oral. It's called the poor man's biologic. Comparable therapeutic efficacy with biologics, it's available in India at present. The last thing is, I do write something called Wisdom Ranki. In fact, I don't write it because I'm an empty fool. Now, once I came back from the hospital to back home at about 12 midnight, and I happened to go through pass by a graveyard. So I just got out of the car along with my chauffeur. My chauffeur thought that ultimately I'll attend Samadhi inside the graveyard. So when I went outside the graveyard and peeped to the gate, I saw the graveyard brightly lit, and the ground, it came to life and told me, this ground which forms the floor when you're alive will soon become your roof. Ego possessions are absolutely futile as far as human existence is concerned. We have to transform our human existence into living. That's very, very important. I write it in a blog called wisdomramki.com. And the last slide will be, as I'm going to, all of us will hit the bed and go to sleep. Scientists still will continue to burn the midnight oil and find out a cure for rheumatoid arthritis. But before that, I always quote Robert Frost and say, the woods are lovely, dark and deep, and I have many promises to give, and miles to go before I sleep, and miles to go before I sleep. And this slide is for those who have already gone to sleep. Thank you very much.
Well, sir, that was really very insightful presentation and very crisp. I think what you said in the beginning of the presentation, by this clarity, I think most of us can start practicing rheumatology from tomorrow onwards. So, sir, we have few questions which need some more insights from you. So, shall we begin the question answers session, sir?
Sure.
Yeah. So, the first question that I would like to ask is, what is the importance of rheumatoid factor in rheumatoid arthritis?
See, the importance of rheumatoid factor in rheumatoid arthritis, it is only for diagnosis. It's a clinical diagnosis, but the presence of a positive rheumatoid factor, it will increase the probability of rheumatoid arthritis. It is complementary to the diagnosis of rheumatoid. That's number one. Number two, very high rheumatoid factor is associated with aggressive articular disease. But the third important fact for rheumatoid factor is, please do not keep repeating the rheumatoid factor every 3 months and 6 months. We don't repeat it. Once you do the rheumatoid factor and you make a diagnosis, there is no necessity to do rheumatoid factor. Some people will keep on doing it every 4 weeks. I do not know why they want to donate blood to a laboratory. There's no need to do the rheumatoid factor. That's important. Right. It's complementary to a diagnosis. Just because it is negative, it doesn't mean it's not rheumatoid. Higher levels are associated with aggressive articular disease. Never repeat the rheumatoid factor regularly.
So the next coming question is, what is the importance of anti-CCP in RA?
See, anti-CCP is a more refined cousin brother of rheumatoid factor. It is most specific for the diagnosis of rheumatoid arthritis. Whenever you are having an investigation done for a rheumatoid arthritis patient, do both the rheumatoid factor and anti-CCP. It's very important. Anti-CCP positive is very uncommon in any other arthritis. That's very, very important. The second thing, if a patient with rheumatoid arthritis is anti-CCP positive, definitely you can say that his prognosis is quite bad and he requires aggressive treatment with disease-modifying drugs. Could be methotrexate, could be combination of methotrexate, can be tafasitinib, or it can be biologics. That's all.
So the next question is, what investigation to be done before starting the DMARDs?
That's a very relevant question. See, I told you all disease-modifying anti-rheumatic drugs are associated with adverse effects referable to the systems like the bone marrow, the kidney, and the liver. You should always do a complete blood count, CRP for monitoring the result. You have to do the liver function test, at least I do an SGOT and SGPT. Serum creatinine and urine routine should be done prior to starting the DMARD. If it is hydroxychloroquine, you have to do a pre-biologic eye checkup, pre-hydroxychloroquine eye checkup. Now, once you start them, every 4 weeks, you'll have to monitor the complete blood count, serum creatinine, SGOT, SGPT, urine routine, every 4 weeks, at least for the first 6 months. Then after that, you can do it once in 2 months. For biologics and tofacitinib, a pre-biological screening, including the tests for HIV 1 and 2, HBsAg, hepatitis C virus, and interferon, as well as you'll have to do the test, a MAN2 test and an X-ray test. That's very important. Okay. And any person who started in biologics, he requires a pre-biologic immunization with influenza virus and pneumococcal vaccine. That's very essential, absolutely essential.
Right. So what, after starting methotrexate, how long we have to wait for the response in the RA?
We have to wait for 3 months. In 3 months, some people will 60 to 70% respond very well. About 30% may not respond very well. So usually within 3 months, they'll have a very good response.
Okay. So when to stop, sir? When to stop oral methotrexate and change over to the parental?
Yeah. When you find a person who's not responding to 15 milligrams of methotrexate per week orally, and you're increasing it to 20 milligrams or 25 milligrams per week, that time you have to switch on to subcutaneous because the drug bioavailability is better. That's very, very important. Up to 15, the stomach will tolerate. You go to 20 and 25, there will be any better absorption. So you'll have to switch on to the parental route, subcutaneous, and it's very well accepted.
Okay. The next question is, sir, when to stop, how to treat RA patients when the patient becomes pregnant?
That's a good question. The best treatment for rheumatoid arthritis in the world is to become pregnant, which I don't think I can prescribe it on paper, especially with the population explosion in most of the countries. Because during pregnancy, what happens is there is a changes in the hormonal milieu of the body. So we have so many hormones which can induce remission. So the best treatment is pregnancy, but they all relapse postpartum period. So whenever people are very simple, I put it 2 ways. One, what do you do to a woman who wants to conceive? If she's on methotrexate, you'll have to stop 3 months prior to that. Biologics, you can continue. Tofacitinib, no, you'll have to stop 3 months prior. When they become pregnant, methotrexate is contraindicated because of teratogenicity. Tofacitinib is contraindicated because of teratogenicity. Then you have one important drug, this TNF blocker. We have adalimumab and etanercept, which can be given safely during pregnancy. No non-steroidal anti-inflammatory drugs in a pregnant rheumatoid patient, because non-steroidals, the first trimester can be teratogenic. In the last trimester, what will happen? They inhibit prostaglandins and people have problems with parturition and labor. So non-steroidals, you can give for a flare-up during rheumatoid 5 milligrams of prednisolone. That's very, very important. So no NSAIDs, steroids are permissible, paracetamol is permissible, no methotrexate, no leflunomide, sulfasalazine and hydroxychloroquine, absolutely safe during pregnancy. Biologics like adalimumab and etanercept can be during pregnancy.
So the next question is very relevant in the current context. What about DMARDs and the COVID vaccination?
That's a very important, relevant question, which and the American College of Rheumatology has given forward certain important guidelines in the treatment of, in the administration of in the administration of disease-modifying drugs in the COVID scenario. Number 1, if a person with rheumatoid develops COVID disease, you have to stop. You can't continue methotrexate. You have to stop tofacitinib. That's very important. And you have to stop the biologic. That's very, very important. Other than that, the most important relevant question is people talk about vaccination. If a person with rheumatoid needs to take COVID vaccination, if he's on methotrexate, he or she should stop methotrexate for 1 week after the COVID vaccine, the first and the second dose. That's very, very important. If he's on methotrexate, Oh God, again, I have to mute the people. It disturbs my concentration. So, thank you. Is it possible to mute that person? Hello? Hello? Hello?
You're audible, sir.
Thank you, because I thought I also got muted. Because at home, especially the wife around, you will get muted very easily. That's why I thought. See, if COVID vaccination, if a person with rheumatoid is taking methotrexate, you can give the COVID vaccine. For 1 week, you should not take methotrexate. That's very, very important. You can continue hydroxychloroquine and you can continue sulfasalazine. There's no problem at all. With respect to biologics, biologics can be happily continued in a patient that's taking COVID vaccination. That's all, very simple.
Sir, what are the contraindications for methotrexate?
Methotrexate contraindication: first, pregnancy. Second, lactating mother. Number 3, a person who consumes a lot of alcohol and has got alcoholic liver disease. In a person with renal failure, it should not be given to patients with liver disease. These are all the important contraindications for methotrexate.
And sir, what is your choice when it comes to giving combinations of DMARD therapy?
My combination of DMARD therapy is methotrexate and hydroxychloroquine. The other combination is I give methotrexate along with leflunomide. These are the 2 combinations which I use in practice. But when it comes to initiation of combination therapy, I personally feel it is better the physician and the orthopedic surgeon get the opinion from the rheumatologist before they start them on these medications, because combination therapy can also have a greater incidence of adverse effects. So it's better to get the concurrence of the rheumatologist.
So the next question is, what are the differential diagnoses in RA?
That's a good question. Because now what happens is everybody with polyarthritis is rheumatoid. That's very, very important. It's not like that. All patients with inflammatory polyarthritis, please ask for a family history of psoriasis. Ask for a history of psoriasis in that patient. See for psoriatic skin lesions on the scalp. It can be beneath, around the ear or inside the ear, beneath the breast, in the groin, and around the umbilicus. And look for nail changes for pitting and onycholysis. Psoriatic arthritis is something which all of us miss. That's very, very important. Second, a young woman with inflammatory polyarthritis, especially rheumatoid factor negative, you should ask for a history of fever, oral ulcers, photosensitivity, and rash, because systemic lupus also initially presents as inflammatory polyarthritis. The third, nowadays we get a lot of post-viral, especially chikungunya. Last but not the least, even COVID presents as a significant polyarthralgia. So the last is, if you suspect rheumatoid arthritis in an elderly man beyond the age of 60, think of a paraneoplastic syndrome, because leukemia, I've seen so many patients with leukemia and lymphoma manifesting as polyarthritis. That's very, very important. In the elderly age group, please exclude paraneoplastic syndrome, at least by history. That's important.
So how do you treat elderly RA patients, sir?
Yeah, elderly RA patients, elderly, they have very fragile renal function. So give them very minimal dosage of non-steroidals. You can give them 5 milligrams of prednisolone. Methotrexate is safe, but you have to be very, very careful if they have renal dysfunction. That's very, very important. Sulfasalazine is a safe drug. I will never give hydroxychloroquine to an elderly person, because they already have visual problems. They may have a cataract, and it will cause chloroquine retinopathy, which we will not be able to identify. Do not give hydroxychloroquine in the elderly. You can give methotrexate, but with caution. I do not use leflunomide in patients. Biologics, I do give in the elderly, but I use it with greater caution and greater surveillance.
Sir, how is being your experience, clinical experience with the latest therapies such as JAK-STAT inhibitors like tofacitinib?
I had very rewarding experience, to be very frank. It's been a very, in fact, after that, the usage of biologics has come down because it's cheaper and more economical. Definitely, I found it very, very useful in the treatment of rheumatoid arthritis, which is unresponsive and it is, resistant to methotrexate. Number two, I even tried before biologics sometimes. So I find the experience very rewarding and not much of very dangerous adverse effects like herpes zoster or deep vein thrombosis. I find it to be quite effective. The point is, as time goes by, we all will know. It may be definitely will become a popular drug. What we need to do is to be confident in using the medication.
One very critical question, sir. What are the common pitfalls in the diagnosis of RA?
The common pitfalls in the diagnosis of RA is very simple. Any patient with polyarthritis is not rheumatoid. Number two, all rheumatoid arthritis patients need not be rheumatoid factor positive. Number three, all rheumatoid factor positive is not rheumatoid arthritis. These are commonest pitfalls. Overdiagnosis of rheumatoid is very, very common. Just because rheumatoid factor is positive in a person, people start treating on disease-modifying drugs. At the same time, it is a clinical diagnosis where you examine the patient and ask for a good history also. That's important. These are the common pitfalls.
Sir, I am aware the time is ticking. It's already 9, but we have some more questions from audience as well. If you allow us, sir, we can take a couple of them.
Sure, if the audience can tolerate my verbal assault, I don't mind.
Of course, I mean, they're quite anticipating, sir, about certain more insights. I'll just take a couple of questions from the audience, sir. They are there in the chat box.
Sir, good evening.
Good evening.
I'm Sudhakar.
Yeah, hi.
National Silsek. So I just wanted to ask you just one question. By considering the advantages with the tofacitinib, can we consider this as a first-line drug? As a monotherapy?
One important fact is, methotrexate is always the first drug of choice. Methotrexate failure, well, tofacitinib also in the European guidelines in the management of rheumatoid, as well as the ACR guidelines 2021. It has gone up the ladder and it is placed in par with biologics. So you have a choice to choose between a biologic and a tofacitinib. My first drug of choice in any situation will be methotrexate and methotrexate and methotrexate and nothing but methotrexate, unless methotrexate is contraindicated in a patient. If the patient is not responding to methotrexate, he's got methotrexate intolerance, or he's got adverse effects due to methotrexate, then in that situation, either you go to combination or you get into tofacitinib or you get into biologics. Before, the guidelines said that no response to methotrexate, you try combination drug, and no response to combination, you get into biologic, and no response to biologic, you go to tofacitinib. Now, tofacitinib has been promoted to be at par with biologics. So either I may choose tofacitinib or I may choose a biologic.
Thank you, sir. Thank you.
Thank you. Is it over?
No, sir. We'll come back. In between, I just wanted to ask you one more question.
Yeah, sure.
Methotrexate cannot be given to the patient. Cannot be given. The patient condition is such. So, can we start with the tofacitinib and will it be beneficial?
When a person is intolerant to methotrexate or he cannot be given methotrexate, you can definitely start tofacitinib. There's no problem. First, what we do, we will try.
As a monotherapy.
Wait. First, we will try sulfasalazine or we'll try leflunomide. If they are unresponsive to both of that, then we'll go to tofacitinib. But the important point, if this patient has got a bad prognostic factor, I may get into tofacitinib. You understand? Sulfasalazine may not act in patients with poor prognosis. Yeah.
Very great, sir.
Sir, what is your take on iguratimod?
Extremely sorry, sir. I have nothing to comment on that because I've never used that molecule. It has never impressed me. I'm sorry, I may be 100% wrong. I don't know the last word in rheumatology. Extremely sorry to say, I don't know about the molecule. I have not used it, patronized the molecule. It has never struck my scientific intellect if you assume that I have some intellect. I have never given to one patient, to be frank. I don't know why. It's not impressed me on the records at all.
Sir, one more question is, how important is it to give folic acid along with the methotrexate, and for how long?
See, methotrexate is a folic acid antagonist. So you will get depleted of folic acid and the patient will develop a megaloblastic anemia. So if I give 15 milligrams of methotrexate per week, then I give 5 milligrams of methotrexate at least 3 times a week. Abroad, they give 1 milligram of folic acid daily. In India, we do not have 1 milligram of folic acid. So if I give Folitrex 15 milligram per week on Sunday, I give methotrexate 15 milligram per week on Sunday. Then I give folic acid 5 milligram on Monday, Wednesday, and Friday. 100% you must give. Folic acid is a must. Methotrexate and folic acid go together.
So one last question, sir. Can we combine along with the biologics DMARDs or the JAK-STAT inhibitors?
Very simple. Combining biologics with tofacitinib is a little dangerous combination because the side effects will be more. But every biologic which is used in the treatment of rheumatoid arthritis, especially the anti-TNF, we always give methotrexate because methotrexate gives better results when combined with biologics. Oh, Oma! Oh, sorry. No. Somebody had come over here, they fell down.
I hope.
No, nothing has happened.
Okay.
It means I put them to sleep. I don't know how many people fell in the house. I don't know. So I speak so loud and you're all right? Good. I think my speech is a good lullaby, like Bombay Jayashree. Now, I don't know what question you asked me.
I asked you, sir, whether is it okay to give along with the biologics conventional DMARDs or
very good.
JAK-STAT?
Every anti-TNF which you give in the treatment of rheumatoid arthritis, you have to give methotrexate because it prevents the formation of anti-drug antibodies and it will also potentiate the action of a biologic. You can combine methotrexate and tofacitinib, but combining tofacitinib and biologic, I wouldn't do that, to be frank.
Sir, any particular cause of RA factor?
Particular cause?
Yeah.
See, it is basically an immunopathogenesis of rheumatoid.
Particular cause of false positive RA factor.
See, these are all immunological reactions. Whenever there is a situation, rheumatoid factor is an immunoglobulin. So whenever there is any condition in which there will be increased synthesis of immunoglobulins like hepatitis, lymphomas, leukemias, Hansen, tuberculosis, the chances of a rheumatoid factor being positive is higher on the cards. That is why it is like that.
Okay. One last question. Do we give influenza vaccine, and how early or how late can we stop methotrexate before giving this vaccine?
That's a good question because methotrexate, they have found that it inhibits the vaccine response, especially to influenza, So if I were to give influenza vaccine, I'll give it only after stopping methotrexate for 2 weeks. Pneumococcal vaccine, there's no problem. So if I were to take influenza vaccine and I'm already on methotrexate, I will stop methotrexate for 2 weeks, then only I'll take the influenza vaccine.
When will you do anti-CCP?
When I suspect a clinical diagnosis as rheumatoid, I will do both the tests for rheumatoid factor and anti-CCP. RA and anti-CCP, like methotrexate and folic acid, go together.
Yeah, I think we are almost done with almost all the questions, and we have got almost 500 participants who are right now live.
Yeah,
And,
fantastic.
Yeah, so that's a very, very good number. So I would like to, bring this insightful session today, sir, to the conclusion. And before that, I would like to thank you for your insightful presentation, which was absolutely giving a crystal clarity for managing the RA cases. So once again, on behalf of...
To be very frank, I would say one important thing. My answers may be correct or may be wrong because I do not know the last word in rheumatology. I stand to get corrected if I'm wrong anywhere. And if I had been wrong, I sincerely apologize for the lacunae in my knowledge. And science is always a changing process. It's like what Tennyson said, the old order changeth, yielding place to the new. What I speak now may be false tomorrow. I stand to get corrected if I've been wrong anywhere. And anybody who found that Waddy's statement of mine was wrong can always email to the people in Sun Pharma, and they can mail it to me so that I can learn from them. Thank you very much.
Sure. We will do that. Sudhakar, would you like to say the concluding remarks? I think
Sorry, Subhash will tell.
Yeah,
Subhash,
yeah,
go
Subhash.
ahead. Sincere thanks, sir. Thank you very much for accepting my request to be as a speaker. And great thanks. Thank you very much. Subhash, kindly.
Sir, sincere thanks to you, sir, for this wonderful deliberation on rheumatoid arthritis. And I'm sure our audience would have definitely got the enlightenment. And definitely it is a clinical oriented lecture. I'm sure it would have benefited all the 500 delegates today participated. Thank you very much for that. And we also take this opportunity to thank all the 500 delegates, 500 distinguished guests who have taken time to participate in this meeting, sir. So very kind of you all. Thank you very much, sir, once again to you. And thanks.
I should also thank the people who listen to me, because if they have not come here, I'll be speaking to myself. And that's not a healthy sign in the COVID time.
Yeah.
Very, very nice.
Our sincere thanks, Doctor. Thank you very much for helping us in disseminating the scientific knowledge across ortho fraternity as well as physician fraternity. Great, sir. Thanks. Today evening is very good. Thanks a lot, sir.
Thank you.
Thank you,
right, sir. Thank you. Have a good night, sir. Bye.
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 Good night. Good happy weekend.
Thank you, sir.
Same to you.
Thanks a lot, sir.
Recording stopped.